Yes.
The proverb.
Final proverb from Somalia. My father has killed a mouse. Will he fail to kill a man?
Mas is looking at you like,
Why are you killing people? Proverb. Small mammal, big mammal. Small mammal, difficult to find, yet you can find it and exterminate it. Big mammal, surely. Is that not much easier? Easy to see, visible, and in many cases loud. So.
It's obvious.
Yeah. Masi, how are you?
Okay. I'm very well.
You're well?
Yes, completely.
Completely well.
Yeah.
That's a good thing. It's always a very good thing.
To be completely well.
To be completely well.
All right. Okay.
Welcome.
Thank you very much.
Yeah.
Asante sana.
Now, let's just get straight off the Ministry of Health is telling us, it's basically sounding the loud alarm. There's mpukurupuko wa ugonjwa wa kipindupindu. Ebu explain.
So,
Start with mkurupuko.
Mkurupuko, an outbreak. Kipindupindu, cholera. So, the definition of a cholera outbreak is one case reported of cholera. In this case, by the time the DG was sending the alert to the counties, they had 61 people who had been confirmed in 6 counties. I think it was, 61 cases in 6 counties. And this was from a wedding, an event in Kiambu. And surprisingly, all our cholera outbreaks actually usually start from
weddings.
From weddings and
large
events.
gatherings.
Yeah, large gatherings. But really, it's the preparation of the food, the food handling. So if one case is a definition for an outbreak 61, you can imagine that should be high alert for everyone, especially near the counties. Kiambu was the one that was reported. So obviously Nairobi and its environs would be at risk. Murang'a was listed, Kajiado, Nakuru, and Uasin Gishu. And this had, I think it's only Murang'a that had one. The rest had
double digits.
Yeah.
Well, Kajiado had 2 as well.
Kajiado had 2, Nakuru 2. Nairobi 17, Kiambu 31. And the nature of cholera, really, it's one of those diarrheal diseases that people can die within 24 hours because of the severe diarrhea that they get, and people actually get dehydrated. So it's actually treated as an emergency. And I think the reason for this alert is so that, one, because people should be treated in isolation because it's highly contagious. And so that, people are able to be treated and resuscitated with immediate effect, and it's able to be contained. But
who are you calling?
I'm not. My phone is doing crazy. Sorry.
Your phone is...
Just go on. Just having a conversation with
Nduzi for which has...
Just continue talking.
She needs an upgrade.
Tell the phone, we've noticed it. Thank you very much.
She needs an upgrade.
Dr. Mati, please go on.
Yes. So the important thing really would be, because now everyone should be on high alert, is to stop the spread of cholera, because if it goes, then it gets to children, then you're seeing a very difficult situation. So all food handlers, I think it's about time that anyone who's in food handling should be able to check and test their food handlers, because that's one of the things that's usually checked in the panel. The other thing is water and water sources. And before I came in, you guys were talking about the drought situation in Kenya. 4.5 million Kenyans exposed, people not being able to access water. And you can imagine if in a situation where there is no hygiene, then cholera would thrive there, because if you're not washing your hands properly, if you're not able to wash things properly, then it becomes an even bigger problem. And so if you imagine 4.5 million of Kenyans, that's about 10% of the Kenyan population, then this could potentially be a very big problem. So I think the county governments, I know they are still settling in. Some don't even have their executive fully onboarded, or people are still trying to find their way. I think for the county governments, those that have been reported and those around those environs, I think it's about time that they activate the disease surveillance teams so that people are on high alert and they know what to do. Should a case be suspected, should a case be reported, to do the isolation and the treatment, and make sure that they do also the contact tracing, just to make sure that everyone is okay, so that they stem the spread of cholera.
Dr. You mentioned food handling. What do you mean, food handling?
Food handlers.
Everybody handles food.
Handling, yes.
Oh,
Remember,
okay.
we're looking at the causes, and we said large gatherings.
Yes.
And culprits, if you look at food handling. Could you...
So the food handlers I'm talking about here are your caterers, your chefs in the big hotels, because these people are preparing food for masses.
Yeah.
It's not like in your household where on average 4 people are being prepared food for, but this we're talking about people who prepare food for large gatherings. So it could be your kitchens in the hospitals, your kitchens in the restaurants, the caterers. We are going into a weekend, there could be weddings and events, whatever it is. So those people who are preparing food for large number of people.
But what is it in the food that is likely to cause this problem that we are speaking of? What is it that's
is it
likely to be?
No, cholera is a bacterial infection.
Precisely.
So it will be contaminated by bacteria.
And where would the bacteria come from? That's what I'm asking.
Oh, it's fecal-oral.
Yes. So it means that when the people who are handling it perhaps haven't observed basic hygiene, there's the likelihood that in the process of preparing the food, they would
contaminate the food.
Water perhaps?
Even water.
So if the water isn't what, or if it's what happens?
This feels like an exam now.
No, it is because cholera has been thus for the longest time. But its important severity and impact has long been lost because we've had other diseases occupying our minds. And yet,
because your water has to be clean, boiled, if possible, or like our the water from what's it called, the water cancels, the name disappears, should be treated to a certain level. So either properly treated water, let me say properly, because this is Kenya, very many things happen. So properly treated water, or if you're not sure of the water, to boil it and only use boiled water.
So
age-old
for
things,
everything.
For everything.
So it's
even
possible,
washing.
Yeah, it's possible that you use contaminated water to wash a fruit or wash, since we're talking about masses of people here at a wedding, if you're washing, tons of fruit with water that's not clean,
you contaminate.
It's very easy to contaminate, and then we can see how that would have happened.
Yeah.
Now, you talked about surveillance systems. Do we have adequate enough to be able to say, all right, Ndu was at a wedding on Saturday, and the person who serviced this wedding in terms of food was this person, and to go beyond that, we know that this was their source of water, to that point, so that you can have traceability.
Before I get to that, the other thing I remembered is in those events, avoid cold foods like salads, food
sandwiches.
Food that feels cold. Only take things that are really hot, because the heat would have killed or inactivated the bacteria. So it's important to avoid the cold items, and generally anyway in those large gatherings, because it's not only cholera that may be lacking in there, but other bacterial infections that would cause food poisoning. Now, on the issue of disease surveillance, yes, we do have, and I think COVID reminded us and kind of strengthened that disease surveillance bit, because cholera, like COVID, is a reportable disease, notifiable disease, I think it's called that, where in the event there is there's a case, as I said, one case is an outbreak. It's supposed to be reported to the authorities, and then now they activate the teams on the ground. Every county has a disease surveillance unit that has staff that now should be able to go and find out where did you eat this, or where do you think you got this from. That's why they were able to trace this to a wedding. Then when you go to that wedding, who supplied the food in the wedding, that you'd know it's so and so. Then now you go and find out, are your staff certified to handle food? Have they been going through the checks to make sure that they're healthy enough to be handling food? Then now you handle it from that point, and then you're able to trace back. So those systems are there, and it's a coordination really between the national government and the county government.
Okay. Yeah. How is it transmitted then from person A to B? Is it possible for one person to infect another?
The people handling the person who has the disease. Remember, if you ever, I don't know if you've ever seen, but people with cholera, actually, there are special beds for persons with cholera because it's I think it's called painless diarrhea. You don't
It's
even
very
It's passing
continuous.
through you.
yeah, it's usually a mess. So in case you're handling somebody with cholera and you contaminate yourself, you don't decontaminate or clean up, sanitize properly after all of that, then you're likely, because you will come in contact with those fluids. Yeah. So that's why even in the hospital, they're usually in an isolated room.
So then usually it's
special
the
beds.
handlers who would essentially pass it on to the next person.
The person who's assisting the person.
caregiver.
The caregiver or the healthcare provider.
Okay.
Yeah.
All right.
So hygiene is, topmost when you're talking about cholera.
Okay.
Yeah.
So essentially what we're saying is that the simple A, B, C, D of basic hygiene are what you actually require to keep cholera at bay.
Oh yeah.
That's it.
Yeah. That's like we did with COVID. If you can employ the same tactics you used during COVID, then they should be able to work. But if somebody has the symptoms of cholera, they're having diarrhea, it's called rice water diarrhea,
Yes.
painless. That's not somebody to stay at home.
Hospital immediately.
Because that's somebody you can lose within 24 hours or even less.
So then what causes this rapid onset of, possible fatality is that you're losing so much hydration, so much moisture at the same time. So you get dehydrated.
You get
really.
dehydrated.
Okay.
Yeah.
Does the bacteria then play as much a role in, the loss of life as the dehydration? Or is it the dehydration caused by the bacteria then that you will see that as a symptom? Not necessarily that it's causing something else to occur in the body beyond the dehydration?
Does it cause something else? I'm not so sure. But I know it's because of the diarrhea it causes and the suddenness that it causes and the severity, it's just you lose all your water.
Yeah.
So you can imagine if 75% of you use water, what happens when you've lost even half of that?
Yeah.
Your systems just start
Shutting
down. Yeah.
True.
So
it may sound like we're asking really basic questions, but I think it's really important for people to hear because it happens. What you're saying, 24 hours is
or less
is like that.
Sometimes even less
And
because
also,
it's usually really bad.
Diarrhea is not something people consider uncommon. Because you eat something that doesn't agree with you or which you don't agree with, and then you have a running stomach, as we call it. So, but when you have a cholera outbreak, a running stomach is no longer just a running stomach.
It's a matter of life and death,
Yes.
literally. So it's not something to wait. The rice water diarrhea, painless, get to the nearest health facility and just say, I think I have cholera, so that they also are able to respond with the urgency that it demands.
So then talking about response across our health facilities, what level of health facility are we talking about? If you're an area where, your dispensary, your clinic, before you then get to your level 2, 3 like that, or are we saying at whatever level everybody should be ready to respond to cholera?
Yes.
Okay.
Whichever is your nearest health facility, they should be able to respond to cholera because it's a basic primary health level care that's needed. So any health facility should be able to, even your nearest clinic or dispensary, unless now the usual issues that you have in Kenya where you don't have basic things. They don't have fluid, or they don't have, I don't know, certain cannulas, basic things. But at the very least, your nearest healthcare facility should be able to respond and attend to somebody with cholera.
Okay.
Yeah. Because it's and as I said, it's a hygiene issue. It's a hygiene issue. So they should be able to, even now, even if they were not aware that there's something happening, they'll be able to alert the disease surveillance units within the sub-county or the county, so that now they're able to respond and be able to trace back and know what really happened. Is it a water issue? Was it a food handling problem?
Yeah.
What was it? So that they're able to stem it at that point.
There is a cholera vaccine.
Yes,
Yes, there is?
Yeah,
So
there is.
Does it work like the rest? That if you get, because I think we've quite a number of people have gotten the vaccine. Does it work like the rest? You get a vaccine, the chances of you then getting the disease later, of course, are slimmed down considerably. And if so, then shouldn't there be a vaccination drive for cholera like we've seen for others? Because something that could lose life in 24 hours, it seems to me that you want to protect a vast number of the population against it.
I think actually, probably that's one of the things government should consider, and especially for younger population, because those are the ones that
Have not had it.
have not had it, or are likely to come across or be infected. So probably something that should be considered. I know when it comes to those conversations now, people start thinking about the economics of it. Does it make economic sense? How often do you have outbreaks, and things like that. But I think it's something that should probably be considered, and even if not en masse, to the areas that are at high risk, areas in formal settlements where water is likely to be contaminated by sewage or stool at one point during the transmission, or in areas where there's water scarcity. So probably it's something that should be considered. Yeah.
I'm looking at these counties from the statement by the Director General of Health. You said what is classified as an outbreak when it comes to cholera is one case. One case is an outbreak. We are talking about 61 cases within a very short time. Wedding took place in Kiambu, 31 cases reported there. From there on, we have 17 cases in Nairobi, 1 case in Murang'a, 2 cases in Kajiado, 2 cases in Nakuru, Uasin Gishu, 8 cases. Those are very many within a very short time. Are they all related to this one wedding? Because the statement says following a wedding, a festival that was held in Kiambu County. Is this what this statement is saying, that all this, the emanation of this is this one wedding in Kiambu that has spread the cholera cases all the way up to Uasin Gishu, Murang'a, Kajiado?
From the statement, I'm not certain, but from the statement, I thought so. Remember, in a wedding event, you get people
come
from far and wide.
Everywhere.
So even if there are few, you'd go back to where you are. You don't know what's happening. Then you get this diarrhea. You're living in a household with other people, and then before you know it, it's not even 20 people who are in the wedding, but it has gone over to 61. So my guess is it was from that same event, but once you've gone to your various other destinations, then it becomes a problem.
And then from looking at it, then it's not just about one person handling the food. It's about many people eating this food.
Yes.
Which means takes us back to water. Right? That the likelihood here is that water was contaminated, and then this water is used either to wash the plates,
Wash your
their
hands.
hands, the hand washing station, or maybe the fruit that was being distributed. There was like a watermelon on top of the plate. As you pick everything else, you end with a melon. That melon was washed using this water. So it's about the water then. When you talk about something like this, do the officials go back into looking at the water and testing the water to make sure that it was an isolated case of infection within the water system something that it's not the water that was piped to this area that had come contaminated?
They should, as in part of that disease surveillance, part of why it is reported is so that you're able to narrow it down to where it came from. So what we said, you check your food handlers in that event. Are they certified? Are they healthy? Are they free of these bacterial infections? Because sometimes you may be carrying it and you're within maybe the 5-day incubation period for some. So you never know. So they'll check those ones.
What does certification matter?
Sorry?
What does why does certification matter in this case?
Because the food handlers, anyone in the food handling business has to get tested. They actually do testing
regularly.
Yes.
How regular?
I think it's every 6 months.
Yes, every 6 months.
Yeah, just to make sure that you're still healthy. And by healthy, I mean you're not carrying any of those
And surely you can't be carrying
this
the
bacteria
for 6 months.
salmonella, this cholera one, so that because if you're carrying it and you're still serving people food, you're likely to cause an outbreak like the one we are seeing. So they check that. You go down and check the water sources, you even check the area. So it's not just about reporting and say, oh, we have cholera, we need to respond, but going back and trying to find out what caused it so that you take care of it from the source.
The institution that we visited just a couple of days ago has such a program in some of its centers. Center for Public Health Research, Center for Microbiology Research. They actually have a program for food handlers, meaning people who work in that industry come to be tested. So it's not just your random lab test. You're talking about research facility level testing. So that by the time someone is at the certification that Dr. Mercy spoke of, that's where you get it. So when a public health officer comes and asks, are your people satisfied? Certified.
that too.
That's what they'll be looking for. It's an authentication that the people who are working here are healthy, they've been tested, they've been examined, and they are certified to handle food.
That the basics have been met.
Yes.
You know, I'm sticking to this is because it sounds like the first thing they want to do is, wewe ni ketera, let a certificate yako. Now, you find that everybody here has been certified. Then you move to the next level. If you find one person who's not certified, then now that gives this public health officer grounds to say, you see, that's why you're spreading cholera.
Meanwhile, it's possible that it was not that person. Yeah.
But there's something else that's happening here, which is extremely positive. I am looking at the speed with which the Ministry of Health has moved, and I am looking at the health facilities that we have in the area where this outbreak was first, not just located, identified, and reported. It tells you that you have a health system that actually works. Okay? Now, my thoughts went in this direction. I said, now, if we decry the state of our health service in the country and the lack of facilitation and the lack of support.
Yeah.
Now, I'm thinking, with all that, the health facilities are able to do this. They're able to tell you, we have this problem. It means you have personnel who are trained, who know what they're supposed to do.
Yep.
Now, imagine if the complaints were not as they are, and the reality was that everything that health facilities require was actually available. Can you imagine what we would be able to do? Even these issues we're discussing regarding the water that may have been contaminated, what that may have caused it, which that may have caused it, you also help eliminate those. Because if you have personnel who are certified, but the supply of water is iffy, what can they do?
And they have no control.
They have no control over that.
No, they do not.
Yeah.
No, they do not.
Let's take a break. 27 minutes to 9 to 10. Dr. Mercy Korir is the boss of science, health, research. What else? Climate.
The future.
In other galaxies.
Now you're adding the other things
Everything.
that I have no control over.
She's here. And we're talking about, it's Health Friday. We're talking about this cholera outbreak and the alert that's been issued by the Ministry of Health to all the counties and all the health facilities and everybody to be alert and be aware.
This is the Situation Room, the only way to start your day.
Donald Wambua says about the Digger Motor Show, we are already here at the site. Say that in Kiswahili.
Tuko site.
Bas.
Hata simu.
Wacha kusumbua.
Tuko
Site. Talking about disease surveillance and CT, just picking from the point that you were raising just before we went to the break, it shows that there is actual work that happens here in
Yes.
terms of disease surveillance. It's reported to the health facility, it's reported to others, and it's escalated very quickly, and action is taken.
Yes.
And then information is then taken back. So this is the work of the national government. In terms of health facilities report, how does it get to the Director General? How does this information get to the Director General of Health for him to then determine that this is the action to be taken?
So it's a whole mechanism. We have a department, I think it's a department of disease surveillance in the ministry that coordinates with the similar structures at the counties. And then, as I said, there are notifiable diseases. Say cholera is one of them, COVID, Ebola, all of those, and others of those that are viral infections. So when there's a suspicion, not even a confirmed case, as long as there's a suspicion, it's reported and that goes up the chains.
So let's start from this. Somebody walks in and finds a clinical officer or a doctor at a health facility.
Yeah.
Okay.
So
Doctor
let's
suspects.
let's work with cholera, because cholera, you make from the history and whatever, you make a medical diagnosis and you initiate treatment immediately.
Okay.
So you report to your immediate boss. Say, for ease, the medical superintendent is the hospital.
Okay.
The medical superintendent will inform the person in charge of disease surveillance. Then they confirm that actually this is the suspicion that we're having here because of blah, blah, blah. And they report that to the director of health at the county, whoever that is.
All right.
So then that now feeds back to national government.
The ministry.
Yeah.
And it goes up the chain
It
pretty
goes
fast.
up the chain, and then now everything else comes down. Because if you need more resources for something, say Ebola, you may need your ChemRes or the national laboratory to do the testing, because it may not be done everywhere. Or if you need to, activate certain isolation, and, there are depending on the disease, there are certain levels of response. So it goes up so that the appropriate response is done depending on what the disease or the suspicion is.
Typically, how long would it take for this information to get to the Director General?
This nowadays it should be a matter of same day, but sometimes because you're not sure is it or is it not, it may take time. But these are things that should be same day, because I know that department at least on a weekly basis they do a report of the disease map of Kenya. So that means they're collecting information on a daily basis from across the country, not just one area. And I know they're active and they work.
And before it's made public, it's verified.
There has to be verification.
Yeah, because otherwise you'll be causing alarm.
Yeah, constantly.
And, you say it and someone says that thing is not true.
For example,
yes,
the case
it wasn't
Nakuru
cholera,
recently.
it was a snake bite. Now you're thinking, hiya.
The cases in Nakuru recently, what disease was it?
Which one was it? The one they were saying it was swine flu.
Swine flu, yes.
Yeah.
So it has gone to the Director of Health at county level, who is then making these announcements and pronouncements. And then he's countermanded by the Director of Health, who says, boss, this is not it. So there are also protocols on who reports,
Yes.
who goes public.
Yeah.
There was a breach of protocol in this particular case, for example. Higher. So, does this justify the Ministry of Health getting 67 billion shillings?
Sorry, repeat that question again.
Does it justify
The Ministry
of
of
Health getting 67B?
Yeah. Why I'm asking this is because
I
there's
don't
a
think
story.
it's actually 67B. I think it's more.
It's more. A section of governors are questioning budgetary allocations to the Ministry of Health, and they want the figures reviewed to support health services in counties. The governors note that health is a devolved function, saying 67 billion shillings allocated to the ministry is too much and should trickle down to the counties instead. This is according to Nyeri Governor Mutahi Kahiga, who says counties are responsible for the majority of health services and therefore they deserve a higher budgetary allocation. He whatever he's saying was also supported by another governor, the Rakanidhi's Mudomi Njoki, who noted that some of the functions carried out at Afya House in Nairobi could be carried out by county health departments, which he argues are closer to the community level and thus more effective to execute. Now, if we look at this, and he also actually said some of this money is set aside for pandemics and such outbreaks. So is there a case for the Ministry of Health then having a budgetary allocation so that if they require rapid deployment, they don't have to go back to counties and say, Kiambu, there was a wedding in your county, now we have an outbreak in Machakos, toa pesa kitu kidogo, we deal with this outbreak. Does it justify then having
okay, so
for national coordination?
This conversation is a hot one, and I watched the vetting of the CS for Health, and she touched on it, and it will all. I think it's going to be a thorny issue. It will need a
conference.
Not even a conference. It will just need a government that is willing to stick its neck out and solve it. So this is how I see it. The Constitution has really defined in the Schedule 4 what is county government function, what is national government function. National government is on policy, of course, on training, and they call it the national referral facilities, and which were, put as KNH, MTRH, Spinal, and Madare, and now KUTRH. But the conversation has always been, and I'm glad the President Ruto said all devolved functions should actually be devolved, and by being devolved, funds should follow. All the resources should follow that function. Now, if you look at it strictly from that constitutional, definition, then it means a bulk of your health function is with the county. So if you look at it like that, then your bulk of the funding that is in the ministry then should follow function and go to the county governments in some functions, because and I think what has been the fear is duplicating roles, where you have many people doing the same thing, so at the end of the day nobody is really responsible. But now the other side of the conversation has been, and the Situation Room hosted Busia Senator Okiya Omtat, is, can we relook at this? Is it working? Can we have a health service commission? And that has been the conversation, so that a certain level of the budget goes to just handling staff, all the staff, because that is the bulk
training
of the budget.
Deployment and all.
I think it's half the budget that goes to county, all your staff. And there have been very many other issues around staff, because when they go for training, what happens to the slot they leave, and all of that conversation. The other bit that now the senator was introducing was from your level 4 up, level 4, level 5, and now the national. Can those be managed by national government then, so that your county governments just handle the primary health care? But now when you start having specialized services, you start needing inpatient care and all of those kind of things, then you have it at the national government. So it may look straightforward, as if it's just allocating funds and sending the funds to the counties. But I think for me, the conversation is, it's been 10 years of devolution. Has what is there been working properly to deliver services to the people? If not, what have been the bottlenecks? How can we resolve them? I think it's about time we had that conversation and really sorted this out once and for all, so that nobody's accusing the ministry of having the bulk of the budget, or we don't have money, or if we give you money, then we don't know where the money is going. Because the other thing is, and we've been seeing this from NHI, for example, NHI reimburses the county facilities money, but it never gets to the facilities. Where does the money go? So you still have things that are out of stock, services are not there. You go to a hospital, you're told to go to the next across the road to buy A, B, C, and D. So it may look as easy, but I think it really needs a lot of conversation.
Serious conversation.
Yeah.
Because even if you look at the schedule 4, I'm looking at it, on those functions that are county specific, county health services, including in particular county health facilities and pharmacies, ambulance services, promotion of primary health care, licensing and control of undertakings that sell food to the public, veterinary services, excluding regulation, cemeteries, funeral parlors, crematoria, refuse removal, refuse dumps, and solid waste disposal. And then at national level, they just say health policy.
Yeah.
But health policy, we're not talking about programs such as these ones that are across the country. Who deals with a pandemic? Who deals with national vaccine?
Who deals with surveillance?
Who deals with surveillance? I mean, if you just mentioned it there, health policy. Have we broken it down to understand what exactly we mean by health policy? And then what is handled at national level?
You know, the ministry has trained personnel, whether it is in health economics or whether it's in costing, who can break this thing down for you and explain to you the budgetary allocations and how they are allocated. But we've had this discussion regarding the county health budgets and the breaking down of it and the actualization of those budgets. That thing is as opaque and as vague as it can possibly get. So whenever one talks about needing more funds and you haven't dealt with the primary concern, okay, this is what you get. Just tell us how it is that you use it and tell us where the shortfalls are, given what it is. Now, that conversation at that level is, as I said, usually really vague. So now you get to the national level and then the vagueness continues at a national level because, okay, money is allocated. Fine, we get it. Budget. Now, break it down for us and tell us this 67 billion plus that you need, how exactly do you need it? Because in the absence of that detailed conversation, what conversation are we going to have? Because we don't know what you need. We don't know what it's going to cost. We don't know why you need it, or you can tell us vaguely. Now, that entire, whether it's at the county level or at the national level, this discussion about finances is not clear. It's never been clear. And when it's asked, the responses are equally unclear. So, can we have the conversation by telling us what you get? What do you do with it? So we know, and so we understand. And so we can also understand where the shortfalls are. But in the absence of that, this let's chase our tail conversation. Nah.
And it should be at both levels, really. The national government to explain, and the county governments to explain, so that now you start from that point. What I said, we need, and I'm glad health is an important conversation. It's an important priority area for this government. And so if really we want to resolve the issues in the next 5 years, because this is not something that you'll sort out in one year even. It will take 5 years, probably 10 years. Then that should be had so that everyone comes to the table, national government, county government. These are the issues, or this is how we spend our money. These are our shortfalls. This is how we think we can do, and have something that really works, because otherwise we'll just continue round and round, and when everyone is responsible for something, then nobody is accountable, because you'll think City did it, City will think I did it, or Ndu did it, then nobody does it.
Right.
So it's about time we know where the buck stops on health.
Okay, so then it who's then, because it looks as though there needs to be there needs to be a rallying call. There needs to be somebody who's going to take the bull by the horns and provide the leadership, because it's clear that needs to happen. So who's supposed to do it here?
The person who's in charge of the policy. The person who's in charge of the policy. That's where the buck stops. So this is squarely
At the national level.
At the national level,
Cabinet
at the
Secretary.
feet of the cabinet secretary and the appointing authority, which is the president.
So do we say then that in the past 5 years, that we've seen things go the way in which they have, to the outgoing CS, to the one before him, would we say then that because the complaints have been for as long as there has been devolution, even before. So then would it be that there has been a way in which their duty has not been properly filled? And is it that to look at those holes that were left, and hopefully that incoming CS Wafula will handle them the way in which they ought to be.
That should be the starting point, to see where did they reach, what did they do, what were the shortfalls, what are the immediate things that are needed to sort out whatever it is. Because if I were her, you just have urgent, you triage, emergency, urgent, good, and those that can wait, so that you have a systematic way of resolving these things.
Yeah.
And apart from the payer issue, which has really been discussed, the NHIF, we need to reform NHIF, money, financing. Okay, that's good. But okay, if you sort that out, if your systems are not in sync and are not working, then this money will come and dissipate somewhere and disappear. So I think she needs to prioritize and really have a good understanding on what the immediate thing to do is, what other people have done, and where she can pick up from, and now be able to reorganize and realign health. And from her vetting, to me, she understood what her assignment is, what she needs to do. So personally, I have some faith, and I'm optimistic that
Because
something will happen, something will move.
Because it does seem that indeed the policy, especially for this particular ministry, it happens in Afia House, but that the practice of this ministry is happening all over the country, and it needs the attention, but it seems to be lost in the ivory tower that is Afia House. It needs to come out.
It does.
It needs to be practiced outside of the doors of Afia House.
It does. As Citi said, there are people who understand these systems and can break down to you everything. Those are the people to have a conversation with.
And they're in Afia House, by the way. And
They're
not-
all up there.
Not the Afia House in Uganda, here.
And Citi, you've been saying, they need to be probably seconded to the counties if some of these things are to
Yes.
work.
Yeah, that's what I'm saying. Get out of Afia House. This is it. Get out.
Does Ms. Nakimisha, in your assessment of her, have the wherewithal to actually have a conversation with the Council of Governors and convince the governors on how they can work together? Because governors, as far as they're concerned, they were elected on a platform of healthcare. Okay? So health is their business. And then here's a ministry that is coming to give you stories, this and the other, and one or two, and supporting this conversation about health services commission and such. That is a political hot potato. It requires political conversations between this health CS and these 47 governors.
I think she does. Remember, she does not come from a straight health, purely health. She's been in the political arena, campaigning, looking for a ticket first time,
She knows the
second time.
language.
So she knows the language of the politicians. She will find her way around. So I have some faith that in terms of the political lingo, she will be able to maneuver and navigate her way around the politicians, the 47 governors, and, have them buy in or have them see the direction in which the Kenya Kwanza government, Ruto's government, wants to take healthcare. In terms of the technical lingo of talking to the stakeholders, the healthcare providers, the other stakeholders, the NGOs, I think she also has that lingo because she has worked in that process. So for me, I think she would be able to, navigate her way, be able to do as the Romans do when she goes to that side, or do as whoever else does as she goes to this other side. So I think on that basis she will. The other thing that I think works for her is this political goodwill to resolve the issues in healthcare. I mean, all governors, everyone said, I'll resolve health. The president himself said, we have to sort this healthcare. So there's political goodwill around healthcare from the people who would make the decisions. And two, also the people working in the health sector want things to work. I was having a conversation with some of my colleagues yesterday, and for them, they would rather work in public facilities. You go, you work in a public facility, you get your time off, you go home. But because you've been trained to do certain things, but your facility doesn't have, you find that you're being wasted. So you go and work in a private healthcare because you have all of this knowledge, all of these skills that you cannot
You're in a
use.
place that can allow you to practice.
Exactly. So if that is sorted out, then you'll find that the chips will just fall in place properly. So I think she comes in better than the 4 predecessors who've been there, because people have an understanding of where the problems are, what the issues are, what needs to be sorted out. And on top of that, everyone is willing to resolve the health
Moving
issues
forward.
once and for all. So I think she needs to strike. I always forget this proverb. Strike on the.
When the iron is hot.
Yes, that one.
Daktari, thank you for joining us today. Over the weekend, make sure that you keep exercising for the 30th. See, you registered for the Standard Chartered Nairobi Marathon.
The virtual one.
The virtual one. You start this Sunday, 23rd. All right. Have a lovely weekend, folks. See you at KICC for the Digger Motor Show.